Thank you for the introduction, and thank you everyone for attending. So with a title like, What Can Medicine Teach Us About Being on Call? I want to start by saying why I think medicine is even relevant to what we do. So all of us are probably at large companies, or eventually, hopefully, large companies, that have specialized teams. You probably have a team that takes care of your databases, and I'm betting it's not the team that takes care of your networks, right? We have specialized skills. And all of these teams support one big application or multiple big applications that make up our company. And medicine works the same way. If you have a brain tumor, you're going to see a neurosurgeon. But if you also have diabetes, and I hope you don't, you're going to have an endocrinologist. And the two of them are going to have to work together to make sure that you're ready for surgery. We're also familiar with service-level objectives. There have been quite a few talks on them. And as technologists, we know about latency, error response rates, and a bunch of other things that are critical. And there's serious problems if we violate these, right? It might cost us money. Shopify is an e-commerce company. It might cost our customers money, right? That might affect their livelihoods, their ability for their business to exist, and that's serious. And medicine also has these. They don't call them service-level objectives. They call them things like post-procedure complication rates. And if you think it's bad when your service goes down, well, it's really, really bad when a patient goes down. So medicine is also old, right? And it's older than anyone's company here, and I know this because medicine existed before electricity. And so on the left here is a picture of an 1860s era surgical toolkit, and if that looks like a hacksaw and some sharp, pokey things, that's about right. But if you go to a modern operating room, you'll see the tools on the right. And these might still be terrifying, but they're certainly not the same as the ones on the left, right? There's clearly been an evolution to more sophistication. And they've done that through science. And they are really good about this, right? They do A/B testing as, I have an idea, and we're going to compare it to a baseline. Because it's unethical to do anything that might make you worse off as a patient. They are serious about this. Their research also requires long-term validation, right? One small experiment worked well. They do retrospective studies, right? They look a decade later and say, are we still seeing these benefits, right? Or in fact, was there an issue that sort of on a global scale we didn't detect? And the research doesn't have to be big, right? They do very small-scale projects, too. They call them quality improvement projects. Something as simple as hanging a sign that says, do not disturb nurses in this area, because that's where they're counting pills, and that's where errors can happen or explode. All the way to huge topics, right? They write books, right? Some are for other medical providers, right? They take the entire field of knowledge into one book. Some are for consumers, right? They want us to know more about cancer or other things that affect our lives. And then they have a bunch of other things, right? Things that are really relevant to us. They look at research around call schedules, time to treatment, and other things we'll get to. But speaking of other things we're going to get to, where are we going in this talk? So I'll talk about the bulk of this talk in ways to reduce incidents, things medicine has done to make their patients healthier and happier, and how we can steal those ideas, how they deal with being on call and the stress around that, and finally, some words of warning. This is, after all, an interdisciplinary talk. We aren't doctors. And there's quite a few things from their culture that maybe we don't want to adopt wholesale. So before I really jump into that bit, I want to tell you a little bit about me. I don't have a medical background. Shopify is an e-commerce company. We're not in medicine. But I do have a PhD. It means I tend to be very interested in research. I've read a lot of research papers in my career, and I'm pretty good at spotting bullshit statistics. The things that sound good but don't really have any meaning in the end. On the other hand, the motivation for this talk came from my wife. I'm married to a doctor. She is a general surgery intern, or at least was when I wrote this talk. And I apologize for coming to Europe to talk about the American medical system. It's just what I know. It should be similar to most of your medical training systems, but not everyone's. An intern is the first, it sounds funny, but the intern year is actually your first year of post-medical school training. It's also known as the first year of residency. That's a 3 to 7 year period, depending on the specialty, where at the end, you will be fully certified to practice on your own without supervision. So as an intern, my wife carries a pager. She could be on call as often as every third night, but often once every 4 to 5 days. A call shift was 12 hours or 24 hours. And in a 12-hour call, she could get 60 pages. To give you about 60 pages in 12 hours means her pager would have gone off from when I started talking to now. It'll go off several more times before I'm done talking. And I was going to do that. I was going to have a pager go off. But I think it would have driven us crazy and PTSD. We would have been unhappy. So in other terms, if she doesn't get a page for an hour, she'll call the operator and have herself paged, right? That's what it means to go have this many pages. And this gave me a great secondhand view. I don't want you to think this entire talk is secondhand view. I've read a ton of research, and at the end, I have citations that you can follow. But it really made me interested in, like, they clearly do this day in, day out. What can we do better? So let's jump into what we can do better. And that is reducing incidents, right? The bane of being on call. And so not all incidents are equal, right? We really have those dumpster fire critical incidents where we'd like to have less of those and more, like, oh, nobody really noticed those incidents. And so this happens in a hospital too. And so to make this better, they created what they called the Rapid Response Team. It's a pager that's staffed by medical professionals, and anyone can page this pager. It doesn't matter if you're the janitor or the chief medical officer of the hospital. If you're concerned about a patient, you page it. The worst case scenario, they come, they evaluate the patient, and they tell you why the patient doesn't need extra treatment. The best case scenario is you've gotten ahead of something, right? You've made a difference because they got ahead of a problem. And getting ahead of problems made real impact, right? 12% decrease in deaths, and that's a serious statistic, right? You can't lie about deaths. That's what you want to stop. Now, I should also say, this rapid response pager is not we're having a heart attack, they're critical, something's gone horrible right now. That's a different team that you definitely want to have and probably do have. And, so now you're thinking, well, if it's not the critical pager, right, why don't you just page their doctor, right? They're getting pages. And the answer is, if your doctor is a surgeon, he might be doing surgery. He might literally have his hands in someone else's body. So he can't come look at something that doesn't seem so bad, but this team can. So the other thing about this team is there's criteria. They have these fancy monitors in every hospital room. You've seen them on TVs, right? They track vital statistics, heart rate, blood pressure, blood oxygenation, and some other things. And the guidelines are around these, right? These are your expected values. If they're outside of these values, and you don't know why, and you don't think it's okay, page. Right? You can page for reasons that are not tied to these guidelines, but they want to give people, empower them to feel like they're not just randomly paging, they're doing it for reasons. So, of course, what does this look like for us, right? We're not going to start monitoring our vital signs. That doesn't help us. But we do monitor our app's vital signs. This is one of our Datadog dashboards. I'm sure you all have dashboards and various things. But we also annotate it, right? The words here basically say, these are our expected values, right? If they start to deviate from this, do something. Now, of course, you probably also have automation that says, if these get really bad, we are going to start paging people. But there's that sort of weird period between green values and red values where a deploy is going on. And so maybe there is going to be extra latency or a couple of extra exceptions. And that might be okay. But if you have a human who deployed some code who's keeping an eye on this, they might be able to say, that's weird. That's trending up. I wonder if we should get someone involved and figure out what's going on before that goes red and flashing red. So another type of incident that I think we all can relate to are the self-inflicted ones. These are the, I ran the right command on the wrong server. Uh-oh. Right? And it turns out this is a human thing. There's a lot of research in a lot of fields discovering that humans are really good, or maybe I should say really bad, at forgetting steps in routine activity. And we couple that to the sort of maintenance we do, which are known as all or none processes. And that basically means there's a bunch of steps, and sometimes those steps are optional, right? Like, did I check if I was on the right server? Is totally optional if I'm actually on the right server. But if I'm not on the right server and I skip that step, well, all of the protection and everything I've tried to set up just goes out the window and you cause problems. So not shockingly, medicine also has repeated procedures. So one I'll talk about is known as the central line. Essentially, you take a catheter and thread it through a vein near your heart to rapidly deliver medicine. This is a serious deal. The kit on the right here contains everything you might need to do this procedure, and I'll explain why that's relevant in a second. But what I want to focus on first is that white piece of paper. That's a checklist. And the first time I thought, there's a checklist? I want someone who knows what they're doing. I don't want some, junior doctor who has to, follow guidelines to do this procedure, right? That thing's near my heart. Well, it turns out checklists are not instruction manuals. This is a slightly different version of this checklist, but it's a lot easier to read. And that first step says, wash your hands, right? The second step says, put the soap on the skin. Right? These are really basic things that I'm not a physician, but I could have, told them they needed to wash their hands and put the soap down. And so you're thinking, great, how does this help? It turns out it made a huge difference. They dropped infection rates with a 5-step checklist from 11% to 0. And now this isn't a statistic you can lie about, right? You don't really care about infection rates. You care about people and keeping people alive. And so what this meant was about 8 deaths in just one hospital over 16 months with a 5-step checklist. And it's hard to quantify deaths, and I know there are agencies that put, values on human lives. But if you're one of these 8 people, this checklist is invaluable. It literally saved your life. Now, thankfully, we tend to be able to automate our problems away. Medicine isn't there yet. But there are things we can automate, right? I know that kernel upgrades or generic server maintenance sort of is a little bit different every time. And so I put together a quick, rough draft of a checklist. I wouldn't say use this one verbatim, right? And it basically breaks things up into before you even started, make sure these are done. The middle chunk here is before you do something irreversible, take a pause, take a deep breath, make sure these are done. And this is the last bit is the after you're done, actually make sure you're done kind of bits. But the previous checklist showed you that was 5 steps. The first version was 27. It was unusable, right? They literally couldn't get through 27 steps. They were just ambiguous, right? And so I'm not at all suggesting this is the thing you should use, just that this is our first step from going from 27 steps to 5. Okay, so I said I was going to talk about that kit again, about everything you might need to do. And so let's talk about what I mean. So that red square is a vial of lidocaine. Lidocaine is a topical pain blocker. Essentially, it's injected into the skin so you don't feel anything when this procedure happens. Because the bottom red thing is a scalpel, and those tubes get pushed through the hole the scalpel makes, that'd be not pleasant. And the vial of lidocaine's $10. I'd happily pay $10 not to feel this procedure go down. I bet all of you would too. The kit itself is about 130, so this vial of lidocaine's 8%. Then I read a study that told me 3/4 of the people who have this procedure done are unconscious. They don't feel pain, because then you'd just be asleep. Right? So this kit's 6% more expensive than it needs to be on the average case, right? Talk about medical, inflation, right? Evil companies packaging this stuff. And then I heard a great story. My wife said she had to do one of these, and her kit didn't have it. And the pharmacy said it'll be 4 hours before we can get you lidocaine. And now she's stuck making this terrible decision, right? Do I cause this patient pain and do it while they're awake? Or do I wait 4 hours and potentially jeopardize getting them life-saving drugs? I'll talk that story later if you want to hear it in private. But anyway, this is a correctness versus efficiency decision. If you use this kit, you've decided you never want to have to make that decision, and you're willing to pay for that experience. The black box, that's the soap dispenser we mentioned in the checklist, right? You'd never run out of soap in a hospital, right? That's crazy to think about until you get a hurricane and your supply chain's disrupted, right? This kit cranks correctness to 110. They're not interested in having something go subtly wrong. And we do this in tech too, right? You probably keep backups for your databases longer than you've ever needed or thought about doing, right? You probably have replication factors that are hopefully higher than you've ever experienced downtime. But sometimes that's not the correct decision, right? 110 isn't great for your garage team that's quickly, rapidly prototyping, right? Their trade-off may be crazy towards downtime, right? They might be wanting 5/8 of downtime, not 5/9, right? And so it's important to be explicit about these trade-offs, right? Think about what it means and do it ahead of time, right? The time to decide that it was unacceptable to lose data wasn't right after you lost data. And so finally, one more class of things. I said she worked 12 or 24-hour call shifts. And I'd love to tell you that everyone leaves the hospital within 12 hours or 24, but they don't. Some people spend days there. But humans need to sleep, and so patients have to be handed off. And at night, they actually will do cross-coverage, where one person will cover multiple teams' patients. So it's quite possible that a new person is going to start picking up 24 patients they've never seen before. And that handoff needs to go quickly, because some of these people are sick. And so they developed a mnemonic. It essentially discusses the stability of the patient, the summary of how they got there, what's going on, the action list, right? What's been done? What does this new person who's going on call need to follow up with? What tests might they need to order in a couple of hours? Finally, some situational planning. Right? If this is your patient you're handing off, you've had them for quite a while. You know what to expect, right? And you have sort of mental ideas of what you could do, right? If this patient's heart rate goes up, I'd give them this drug, right? If this other scenario happens, that's actually okay. Just wait it out, right? And passing that knowledge off to the person going on call is invaluable, right? They're getting 36 new patients. They don't have time to think about all of these scenarios. And so if you can give them a cheat sheet, it's fantastic. And then finally, this last step is active listening. This is basically where the receiver repeats back what they understood and is a great tripwire to make sure that everyone's on the same page. So hopefully you are doing on-call handoffs. We certainly are trying to do them. But you might have noticed they don't always help in the ways you'd expect. Right? So in one study, they did this in 9 hospitals, and it made a difference about 2/3 of the time. And that seems low, right? I told you this previous checklist literally saved lives. Why the heck is this one roughly sort of making things better? And to get into that required a little bit more research. And it turns out, in this grand scheme of problems, they're often divided into 3 classes. The first is simple, tying your shoe. 1 or 2 steps. Once you figure out how to do it, you'll get it right from, you won't get it wrong usually. The next are complex. I like to talk about launching rockets to the moon, right? There are a lot of steps in that process, a lot of simple steps in this big, complex process. But once you figure it out, you'll have a pretty high success rate, like above 80%. The final are complicated. These are like raising children, right? The strategy you used for your first kid probably didn't work on your second kid 100% of the time. And you know people do it successfully, but there's no guarantee that it'll happen to you, right? And these on-call handoffs turn out to be complicated problems in medicine. There are human factors involved. There's time factors involved. And they found that as they added more and more rules and more bureaucracy, it didn't get better. It actually gets worse. And so it's really worth thinking about your problems and saying, is this complicated, right? Is adding more procedure and more process going to help? Or is it actually just going to piss people off and make it worse? But it's not to say we shouldn't try. And so here's my version of an on-call handoff, right? Severity of everything that's happened or might happen. Talk about the severity, the summary, how did it arise, what's been done. I think it's even more important that we talk about action lists. Usually when I go off call, I will own all of my issues, right? Unless the active thing's going on, in which case I will tell the person, right, you actually need to follow up with this P1 ticket that's going on, right? That's your responsibility. Finally, contingency planning, right? If this issue comes back, go update this ticket or raise the priority. And then again, I really do believe in active listening. I think this makes a big difference in how we hear and share knowledge. So with that, let's transition a little bit to actually dealing with being on call. If you're a doctor, you expect to see a lot of new patients, to get paged, and to deal with that. And so if you ever had the joy of going to see a doctor, maybe your ear hurts, you check in at the doctor and say, hey, front desk, I'm here because my ear hurts. And they say, great. And then you go see a nurse, and you tell her, I'm here because my ear hurts, right? And she's taking notes. And then the doctor walks in and says, why are you here? And now you're losing your mind, right? Because in 15 minutes, you've told 3 people my ear hurts. I see them taking notes. Like, why can't you be bothered to, read the damn notes? And them in America, so this is really expensive. Like, I sort of feel like a consumer, like, can't you treat me well? But it turns out the doctor's read the note. He thinks he knows why you're here. But he's asking because when I said my ear hurts, I waved my right arm by my ear. And the nurse wrote down, right ear hurts. But it was my left ear, right? And so the doctor just came in, looked in my right ear, and treated me. It'd be not great, right? Like, if my ear hurts, I'll probably come back later. But if something more severe happens, it's a real cold comfort to a doctor to say, oh, the note was wrong. Doesn't make you sleep better at night knowing that the note was wrong, right? When you could have caught it. And they have these built-in tripwires into their systems, right? They repeatedly ask the same question. Also because sometimes the story changes subtly, not just because, it was written wrong. And so this, I think, also happens in our incidents. I can think of cases where I got paged into an incident and someone said, it's not the database, don't look there, I already have. And an hour later, we were looking at the database because what the person saw was queries per second was 0, right? Like, the application's not sending any queries to the database. How could that be the problem? Well, the problem was the database was deadlocked, right? If we had looked at a different graph, we would have saved a lot of time figuring out that, in fact, all the application threads were blocked, blah, 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 right? This stuff happens to us, right? Asking the right questions, making sure you see the data behind people's conclusions goes a long, long way. Secondly, medicine is very good at getting help, right? This is a very common scenario. The nurse is concerned. They page the junior doctor in training, right, the intern. The intern doesn't have the answer. They page the senior doctor in training. The senior doctor in training doesn't have the answer either. He pages the attending physician. So at this point, this is the person who should be certified to practice on their own. You'd expect them to have the answer, but they might not, right? They've got a department chair. They have someone they can escalate to. Or maybe you have 2 different people, right? The endocrinologist and your neurosurgeon are disagreeing about the best course of action, right? And then they need someone to be a tiebreaker, someone else to join in this conversation. And in the middle of the night, if that's when the surgery needs to happen, they'll page the chief medical officer of the hospital to help. Right? I want you to think, what would it take you to page your CTO, your director, right? Like, how bad would things have to be, instead of thinking, what's the best thing for the patient, who cares if they're asleep or not? Right? This has other benefits we'll talk to in another slide. The next is work-life balance. Medicine it's stressful, right? 60 pages in 12 hours, 60 pages in a week, and I'd be losing my mind. I can't imagine 12 hours, right? And to make up for this, they do post-call days. After you come off of call, they acknowledge it's stressful and say, you get a day off, you get a day to recuperate, to sort of make up for how bad it was. They also do cross-coverage, right? I said someone going on call could pick up 24 patients they've never seen before. The idea here is that because of these long escalation chains, they can handle the first, they can be the first person to get paged, right? And if you have surgeons cross-covering other surgeons, they generally know what to do, right? They can generally help 2 other people have a good night's sleep by being that front line of defense. Now, this only goes where you have similar training, right? Your neurosurgeon isn't cross-covering for your endocrinologist, but for other surgeons who do have a similar background, this works. And I think we can leverage that too. And then finally, I don't do my best thinking at 3 a.m., right? In fact, it's like 3 a.m. at home right now, so I'm impressed I'm talking. And doctors don't either, right? They are keenly aware that 3 a.m. is not the time to make a critical, irreversible decision. And so you'd call it stalling. They might call it stalling too. But they'll punt a decision to the morning team, right? Patient's hungry, right? That could actually be a page. Well, maybe they need surgery in the morning, maybe they don't. Let's just put this off a little bit. And we can do this too sometimes, right? There's a lot of jobs in the job queue. I'll turn up the workers, because I'm on Kubernetes and scaling up's easy. And in the morning, when I'm not exhausted or I don't have to page someone else, then we can really dig into it, right? A couple of dollars now might keep me from making a bad decision that will take a lot of dollars or a lot of time later to fix. And this is nothing to be ashamed of, right? This is good decision-making, right, by being upfront about the limits of human abilities. Okay, so finally, some words of warning. We're not doctors, and this is, and we want to be careful, right? So the problem with being on call every other night is, and I'll let you read the answers and figure it out. Okay, this is like the SAT, right? One of these things is not like the other. That's the damn answer. Yeah. The problem is you miss half the good cases. And I'll totally admit, being on call is a great way to learn, right? There's a little bit of stress, that little bit of autonomy, all coupled together really makes a big difference. It's also a good way to be burnt out. It's such a good way to be burnt out that medicine no longer allows doctors to be on call every other night. They're now limited to every 3rd night. Not kidding. But it does lead to real burnout, right? And so I don't know about you, but I can't sell my call shifts to other people. Like, it's just not something our company does. I've never seen it. In medicine, it's totally not true. They get a value associated with the call shift, and they're happy to sell them to their partners or take them on if they want to make some extra money. And so as a result of this, it's really easy to see that in neurosurgery, for example, the value of these call shifts is going up. In fact, being on call is worth 20% of their salary. And I don't know about you, my call's not so bad that I'd give up 20% of my salary to not take pages, but the neurosurgeons sure are. And here's another quirk of the American medical system. The average neurosurgeon makes about $600,000 a year. So when I say they're giving up their call, they're giving up 6 figures of money because they don't want to be on call. It's that bad. So let's not get there. Let's not become a field that, gets us burnt out, who takes too much call and we lose our minds. And with that, quick summary, right? Establish procedures to help your on-calls before they need them. Question everything when you get paged, and acknowledge being on call is stressful. And with that, I will plug some of my coworkers' talks at Shopify. We should definitely hear Nico talk later, and I'd be happy to take any questions with my remaining time.